Intraoperative management. Temperature. Causes of hypothermia. Less than 36 degrees. Intraoperative temperature losses are common. 90% of intraoperative heat loss is transsubcutaneous due to environment, cold room, IV fluids, instruments, open wound. Prevent with forced air, warm water blankets, heated humidification of inspired gases, warmed IV fluid, and increased or temperature. Causes of hyperthermia more than 37.5 to 38.3 degrees Celsius. Drugs, atropine, blood transfusion reaction, infection sepsis, medical disorders, thyrotoxicosis, hypermetabolic states, malignant hyperthermia, neuroleptic malignant syndrome, pheochromocytoma, overzealous warming efforts. Impact of hypothermia less than 36 degrees Celsius. Increased risk of wound infections due to impaired immune function. Increases the period of hospitalization by delaying healing. Reduces platelet function and impairs activation of coagulation cascade, increasing blood loss and transfusion requirements. Triples the incidence of VT and morbid cardiac events. Decreases the metabolism of anesthetic agents, prolonging postoperative recovery. Heart rate, cardiac arrest, pulseless arrest occurs due to four cardiac rhythms divided into shockable and non-shockable rhythm. Shockable ventricular fibrillation (VF) and ventricular tachycardia (BVT). Non-shockable asystole and pulseless electrical activity (PEA). For VF or BVT, key to survival is good early CPR and defibrillation. For asystole or PEA, key to survival is good early CPR and exclusion of all reversible causes. Reversible causes of PEA arrest 5H and 5T. 5H hypothermia, hypovolemia, hypoxia, hydrogen ions acidosis, hypo or hyperkalemia. 5T tamponade cardiac thrombosis, pulmonary thrombosis, coronary tension, hypothorax, toxins overdose, poisoning. When a patient sustains a cardiac arrest during anesthesia, it is important to remember that there are other causes on top of the H and T to consider: local anesthetic, systemic toxicity, last, excessive anesthetic dosing, and others. For management of cardiac arrest, see Appendix A32. Intraoperative tachycardia. Tachycardia, heart rate more than 100 per minute, divided into sinus tachycardia, heart rate 100 to 150 beats per minute, or Supraventricular tachycardia (SVT). SVT can be further divided into narrow complex and wide complex tachycardia. Narrow complex atrial fibrillation flutter, accessory pathway mediated tachycardia, paroxysmal atrial tachycardia, wide complex VT SVT with aberrant conduction. Causes of sinus tachycardia: shock, hypovolemia, blood loss, anxiety, pain, light anesthesia, full bladder, anemia, febrile illness, sepsis. Drugs: atropine, cocaine, dopamine, epinephrine, ephedrine, isoflurane, isoproterenol, bancuronium, and withdrawal. Hypermetabolic states: malignant hyperthermia, neuroleptic malignant syndrome, pheochromocytoma, thyrotoxicosis, serotonin syndrome. For management of tachycardia, see Appendices A33. Intraoperative tachycardia. Tachycardia, heart rate less than bradycardia. Bradycardia, heart rate less than 50 beats per minute. Most concerning are second degree Mobis type 2 and third degree heart block, which can both degenerate into asystole. Causes of sinus bradycardia: increased parasympathetic tone versus decreased sympathetic tone. Must rule out hypoxemia. Arrhythmias: baroreceptive reflex due to increased ICP or increased blood pressure. Vagal reflex, oculocardial reflex, carotid sinus reflex, airway manipulation. Drugs, for example, suprachoroidal hemorrhage, opioids, edrophonium, neostigmine, halothane, digoxin, beta blockers. High spinal epidural anesthesia, hypothermia, and hypothyroidism. For management of bradycardia, see Appendices A33. We finished that section A12 now, and we're gonna continue next episode about blood pressure. Thank you and see you again.